Hello, welcome to HFMA Talk, the podcast for NHS Finance. I'm Sarah Day, Policy and Research Manager at the HFMA. In today's podcast, we're looking at the MedTech funding mandate, and I'm joined by Sarah Tyers, who is the MedTech funding mandate policy lead at NHS England and NHS Improvement. So hi Sarah, thank you very much for joining us.
Hi Sarah, thank you for having me today.
So can you start by explaining what the MedTech mandate is and what your role is around it?
So I lead the MedTech funding mandate here, and I'm part of the Innovation, Research and Life Sciences team. The mandate is a really new policy. So it launched in April 2021 after being delayed due to COVID, but it did get launched last year in 2021. And it's an NHS long-term plan commitment to get NICE selected, approved cost-saving devices, diagnostics and digital products to the NHS more quickly, to increase innovation across the NHS, basically. And the way it aims to do that is to remove barriers to innovation. And the AAC, which is the Accelerated Access Collaborative, has been working with innovation together with the AHSNs, which are the Academic Health Science Networks, for years, looking at different innovations. And what they've learned is there are barriers to innovation. Finance is one of them. Being able to fund the technology is a barrier. So the MedTech funding mandate helps innovation by removing the barrier, and it requires commissioners to fund the technologies when approached by healthcare providers that want to implement the technology. And if they're supported by the MedTech funding mandate, then the technologies have met several criteria, which makes them worthwhile implementing. So the criteria in for 21-22 was that the technologies had to be cost saving, and they had to be substantially cost saving, so saving more than £1 million per year after 5 years of implementation. They had to save money within 12 months, so a fast return on investment. They had to be proven by NICE, so an MTG guidance or DG guidance, that's a medical technologies guidance or a diagnostic guidance, had to have been published before a certain date, 30th of June, to be included on the policy. And that guidance had to state that it was recommended for use in the NHS, not just for research purposes. And that guidance is backed up by evidence, and it will also have a resource impact assessment, which shows cost savings. So providers can go in and put in their eligible population for that technology and understand how cost saving that is. It had to be affordable for the NHS as well. So a budget impact of 20 million couldn't be breached. So the cost impact, that's similar to medicines guidance, what's expected for medicines to be implemented. And then the last criteria for 21-22 was that it had to have been supported by the Innovation Technology Payment Programme previously. So the 4 technologies that met this criteria were well known to the team, and had good spread and adoption. The Academic Health Science Network knew a lot about them, and they were, great products to begin the MedTech funding mandate policy and get that national spread and adoption. So that's the MedTech funding mandate, how it started, and we're just about to go into the second year, where we've reduced the criteria slightly. it doesn't have to be supported by ITP any longer, and it can make cost savings within a slightly longer time. So we're looking at an interesting year ahead with some technologies that we're a bit less familiar with, and we've been working hard to get to know them very well.
And just picking up from about you, looking at some of this work, you come from a costing and finance background, don't you?
Yes, that's right. Yes. So personally, I've worked in the NHS since I left school. I've been in finance most of my career. I think I'm in my 25th year in the NHS now. And what was nice about being a costing practitioner was understanding all the elements that go into treating a patient. When you're in financial management and you look at sort of departments in isolation, when you look at costing, you understand why those isolated departments may be overspending if a specialty is demanding more of those services, and then understanding why those services are overstretched, being demanded more, is really interesting. And I came into this work because I had a meeting with someone that worked in the Accelerated Access Collaborative, talking about innovations and how the innovation would disrupt a service, but then make it more efficient by enabling patients to be seen quicker, or um, less bed days required following treatment maybe, or um, a diagnostic which meant the treatment time could be reduced. And this was fascinating. This really resonated with the work I'd done in costing, and when I was working at my local provider. When you understand how clinicians want to change their services, and we use the costing data to do that, we're looking forward to the time when we can see these MedTech funding mandate technologies in that national cost data, so we can understand a picture of the effect that they have, because they are disruptive. They will disrupt a service, but after a period of time, that service should be more efficient, because the cost savings we talk about are very often a resource saving. So it might not be cash that you're saving, but it might be valuable resource, which with COVID recovery could be
Yep.
seen as more valuable than cash at the moment, more valuable than the great British pound at the moment.
So just listening to you, the technologies you're talking about, as you say, they're proven, they're shown to save resources and support patient care. So why is the mandate needed? Why aren't people just doing it anyway?
So I see this policy as a collision of minds. As an accountant in the NHS, I never used to look for innovation myself to help maybe with cost improvement programs, or solve problems in terms of backlog. Um, Accessing theatres may be difficult. That wasn't the job of corporate teams in a provider. Often clinicians would get excited about an innovation, come to the finance office and want to understand how they can raise the investments for the technologies. This policy requires commissioners to fund them, but it shows the commissioners what technologies they are, how they benefit, tells the story around the resource saved, the benefit to patients, which is really important, and brings them into the innovation space without them having to go researching themselves. So we do a lot of work to understand the very best technologies that NICE give guidance to, and bring those guidances in this policy to the doors of commissioners and finance colleagues in providers. And then we also hope that the clinicians would also be keen, and that brings those two worlds together. The clinicians that want to innovate and use these technologies because it's better for their patients, giving finance staff the vision of a resource or a cost saving, We also work with procurement, so we try and make sure these technologies are available on NHS supply chain. So we remove procurement barriers and make that implementation as easy as possible, because innovation takes a lot of time and the barriers just lengthen that time. So if we can remove some of those barriers and get these technologies out faster, then we can see the benefits as a whole system, as well as the patient, and locally we can see, help towards the backlog that we're facing with COVID, etc. So that's the aim. That's why we see a need for this policy, is to speed up that process, and we can help do that.
And how do you tell people about them? I'm assuming you have a communication route to tell people about the new technologies and how it can help them.
So that has been really difficult. The policy was launched in COVID, and in April 21, we were still really battling, and NHS England were not really allowed to do much comms around anything that wasn't COVID related or related to the vaccine. So communication was very low key. We did a national webinar, and we've just done another national webinar, which we've just received the recording for. So we have an NHS Futures site which people can join. So a MedTech funding mandate workspace on Futures NHS. But our main allies in this policy is our delivery partners that help us get this policy out there and that's the Academic Health Science Network, and they work with us, and they work locally in their regions with that rich regional knowledge to help us promote the technologies. And they also know in their local healthcare providers who to go to talk about these technologies as well. So we do national comms here from our team, and then locally the Academic Health Science Network are working hard to promote this and help implement as well. So that is another benefit of the policy, is that the AHSNs will help with the project management, bring all those people together in the room that we talked about earlier.
So obviously with the AHSNs going out to the people that they are already linked with, but who tends to drive this locally? Does it come from providers, or is it coming through commissioners in terms of trying to encourage the uptake?
It's a mixture of both, depending on the region at the moment. We have some academic health science networks saying that the Eastern region that have set up a forum of commissioners, and we meet quarterly and go through the providers in that area and understand where they are in the uptake of those technologies. And then we've got providers who have really keen clinicians that want to access the technologies and help ask for help building the business cases to take to their commissioners to understand if they're for the funding. So there is a real mix across the country of who's engaged. We've just done the national webinar, and that like nearly 600 people signed up, which was and it was a real mix of commissioners and providers. And what we're feeling now about the policy is that, and what we hope is that they both want to do it together, and that's the most sustainable way of implementing technology, is if both parties are keen and understand the benefits. And most of the technologies, there's great patient stories behind the technologies, which makes you believe that implementing them is the best thing. So yeah, so it depends on the region and the links that the AHSN have got, if the links are stronger in commissioners or if it's stronger in providers.
So just thinking about that, with you saying that it works best when both parties are working together, presumably with the move towards integrated care boards and more integrated working, that's a positive move for your policy? And are you expecting anything to change as a consequence?
The main policy that supports the MedTech funding mandate is the National Tariff Payment System, or the NHS payment system. And that really is moving away now from activity-based payments and from site agreements and looking at areas to support ICSs. And the way we describe that implementation process, and it's really best to understand sort of what your services were before implementation, during implementation, and after implementation, so that you get a really broad idea over a period of time who benefits and where the costs are made. So where the technology is purchased, that could be in the acute sector, but then who benefits. So for us, we've seen technologies that are purchased in acute sector, but will bring benefits not only to that acute provider that's purchased the technology, but we may also see those benefits in the community. And we'd really like to broaden the scope of the technologies we look at. So look at technologies maybe in primary care with ICSs. I think that'll be more possible, less risk involved. There'll be less focus on who pays, who gains. It'll be a system-wide view, which I think will be even more beneficial for the technology and the patients.
So the aligned payment and incentive approach then is exactly what you need to make this work.
Yeah. So the cost of the technologies in the national payment system are on a pass-through basis, but the fixed payment, the main payment, can be used to look at those project costs. So that initial investment, maybe a change in IT infrastructure. There may be the cost of the project group can be substantial. Maybe training, how do you backfill while people are being trained, etc. So broad, the national payment system has helped us to think broader about, well, how do providers handle the other costs that are involved in implementation. And it'll be great to start thinking about the technologies over a longer period of time. We tend to focus in single financial years, but the MedTech funding mandate policy understands that not everyone's going to begin implementation on April 1 and it be sorted by the 31st of March. That's not reality. So the policy will support technologies over a longer period of time, enabling more flexibility for that conversation with the commissioner to say, well, if we implement at a certain time and after 12 months, the cost can then become part of the fixed payment, the business as usual, but that extra funding will really help to implement well first time and get those patient pathways changed and feel those when the benefits are realised, like really feel it across the system.
So just to pick up really the name, the MedTech funding mandate, there isn't funding that goes with this, is there? It's part of the commissioner's allocation that they
That's
already
right.
get.
Yes, it's a very cleverly named policy. It grabs people's attention, but there is no additional funding. And so, yes, it comes from it's the commissioners that are mandated to fund the implementation of a technology when the provider, wants to do so. And that is from existing allocations because of those cost savings that we check are real. And those, it isn't cash saving, so it's not a great cash saving scheme. And we have to think more cleverly about it and think about that resource and how it will be redeployed. So yes, it grabs the attention because of the name, but we have to think a little harder about it than acquiring innovations for free almost, because that in itself brings different habits that haven't worked in the past, and that's why the national when this policy was consulted on back in December 2019, that existing allocation was supported and
Yeah.
has been supported again in the national tariff consultation.
And there's quite a focus, obviously, at the moment around efficiencies. There's efficiency target that's in the tariff, and then the announcement from the Treasury that that's going to be doubled. And I assume that you can link this in with delivering efficiencies for systems, and that's perhaps one of the areas where there will be more focus.
Yeah, hopefully as we get to work with providers that are early implementers, we can monitor how they've gone and use their implementation as a case study to show, real life evidence of the benefits and outcomes that come from that implementation, and build case studies, and you know help build the business cases to show those efficiencies that are made. So hopefully this will be looked at as a good tool.
Now, we've been talking all the way through, we've been talking about technologies. Let's talk about what some of those technologies are. Let's have some examples of the sort of thing that this is enabling people to do.
So from the 1st of April 22-23, there are 11 technologies supported by the MedTech funding mandate. So the first year there were 4,
Mm.
and we've discovered another 7 which meet the criteria. So for the first year, the 4 technologies are, one's called HeartFlow, which is a cardiac CT scan. It takes the data from a cardiac CT scan to produce a 3D image of the heart with estimated flow through the heart, and it will estimate where the blockage is, and enable faster diagnosis. So a clinician will understand if a patient needs to be stented quite quickly, or if actually a medical route can be taken for that patient. So that speeds up the diagnosis of that. Another technology is helps rule out preeclampsia. It's a diagnostic test that rules out preeclampsia in pregnant ladies, so they may be showing signs of preeclampsia, and together with a clinical assessment, they can use the test to reassure that lady isn't preeclamptic and won't develop it for another 7 days, so they can go home safely to the care of their midwife and the community, allowing them to go back to their families and releasing resource in maternity units.
And we spoke about that preeclampsia technology previously, and you were talking about how that can also support organisations to address some of the health inequalities they might be experiencing in their
Absolutely,
area.
absolutely. So our BAME communities tend to be more hypertensive, so there is a focus in the northwest. My geography is not great, but to make sure that technology is available, that diagnostic test is available, to reach out to that high risk group and make sure that they're safe. Um, so yeah, there's a lot of work on those inequalities that goes on behind the scenes of the MedTech funding mandate.
And those two technologies you've just mentioned were already approved last year, so that means
Yeah,
that they show a payback within 12 months. Is that right?
yeah. So we have had it's been tricky for HeartFlow because with COVID, some CT scanners have been earmarked for COVID patients. So actually, access to the scanners has been a difficulty. But that means there is a backlog now of steady chest pain patients, and it's really important that they get to their treatment quicker, um, to avoid that case getting serious.
Mm.
So we're seeing an increased use in FFRCT now as things start to ease up in the hospitals, and those CT scanners become available for more general use.
And so what have you got coming online then from April?
So because we don't know about the technologies as well as we knew about the 4 technologies. So coming up from April, there are 4 technologies that actually treat the same thing. They've all got different nice guidance, but they're all ways of treating benign prostatic hyperplasia, which means for older men an enlarged prostate that interferes with bladder flow and therefore interferes with day-to-day life. So again, COVID has seen elective surgeries such as BPH surgery not done, so we've got a real backlog. And we've been working with the GIRF team on these 4 BPH technologies. We wouldn't expect every trust to be implementing all 4 technologies. And so we're working with the GIRF team, the Get It Right First Time team, the urology team, who are keen to move away from traditional monopolar TERP and move towards these new technologies. So there's different methods of ensuring that that prostate isn't getting in the way of the bladder and the bladder flow. So there is Resume, which is it does it by steam. Urolift is actually tags which physically move it out the way. There is a bipolar TERP. I think I've got that right. So there is a plasma system and a green light laser system. And as I say, they all treat the same condition. There's a real need across the NHS to reduce backlogs and reduce the number of men that are actually dying with their catheters in because they didn't get the surgery they needed. So that's been great to work together with the Academic Health Science Network and the GIRF team to make sure that we can support implementation of technology. And again, this is a health inequality in older men. So a great project to be involved in. The other 3 technologies, so that's 4 technologies in the same space. There's 3 more technologies. The first one is a technology which helps chronic sinusitis without the need of theatre time. So traditionally, patients with chronic sinusitis can have surgery, but something called Express is a balloon dilation system which is inserted into the sinus cavity, inflated with water, and it reshapes that sinus cavity to make sure that it drains and it's no longer blocked, which can be really uncomfortable and can be done in a clean outpatient setting, like an outpatient procedure setting, rather than using theatres. So we're very excited about that one. Another technology is called Topaz. It's a digital chest drain system. So a traditional chest drain system would use suction, and you would have to stay still while you had the chest drain in, and monitoring the air or fluid coming away from that chest cavity is done manually and visually. So removal might not be at the optimum time. But with Topaz, it's a small, compact digital box with digital readings. So the patient can be mobile, so they can, after surgery, they can move around to use the toilet, etc. So it's great for post-surgery recovery. And the digital readouts mean that the chest drain can be removed often earlier because the readings show the optimal time for removal. And then the final one is Spectra Optia. This is a technology which helps sickle cell patients. When sickle cell patients go into crisis, they need red cell exchange. And this apheresis machine will do that automatically. You can have a manual exchange procedure which takes a lot longer and is much less effective. So this apheresis machine is faster and more efficient, and the need for further therapy due to iron buildup isn't needed. So that's a great technology that we'll be supporting too.
It occurs to me, listening to you, that the conversations you have at work now must be a long way removed from those you used to have as part of the finance team. You've learnt a
Yes,
lot,
they're
I
very
suspect.
they are very detailed. You get very into the patient's story, and I
Mm.
think we try and convey that in any comms that we do is understanding those patient benefits, but actually that then filtrates back into the system, and it's really important.
I'm just listening to some of those technologies you were describing and linking back to the comment around efficiencies a little while ago. There's so much there that you're describing that allows people to treat conditions differently, reduce waiting lists, free up theatre time. It addresses so many pressures that we're currently facing, doesn't it?
All those things, yes, definitely. And some of the technologies that we're supporting in last year, so we support something called Securicath, and that keeps a patient's PICC line in place without the need for adhesives. So things like the Securicath and the Topaz machine have great patient safety benefits as well. So the benefits, hopefully make commissioners and providers really want to implement together with the clinicians as well. Hopefully that desire comes across, and then everyone will want to do this. And then the barriers then become that you can overcome them if you've got a big enough belief that something is the right thing to do,
Yeah,
and you understand that other people are doing it as well. So you don't want access to be a problem. So, equity of access is really important. Then
yeah.
hopefully everyone can be doing it together and learning from each other and telling each other, the benefits. That would be brilliant.
So for somebody listening to this podcast who knew nothing about it until they've been listening to you talk for the last half hour or so, the best thing for them to do is really to go to the Future NHS site, I'm assuming, to find out a bit more.
Yeah, we have the Accelerated Access Collaborative has a MedTech funding mandate page. So you can pop that into Google. It's part of NHS England website, and it's part of the Accelerated Access Collaborative How Can We Help sections. So it'll
Yeah.
come up as MedTech funding mandate. We've got a single page that links to the guidance. And yeah, the Futures NHS site has more tools. So we're hoping to get our recent webinar on there. If you join, you'll receive emails about future events, frequently asked questions. Policy sadly doesn't capture absolutely every scenario. So when we're asked queries, we make sure that those queries are shared with everybody in case they come across the same thing. So we have a document of questions too. So it's a really useful area to join up to.
Brilliant. Well, thank you, Sarah, for your time today. That's been absolutely fascinating, and I've learnt loads about things I've never even heard about before. So that's been really interesting for me, and hopefully it's been useful for those listening. So that's been great. Thank you for your time.
Thanks ever so much, Sarah. It's been great to be here.
Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up with future episodes.